Thank you very much, Manu. Just in the interest of the time, we're going to move on with the next presentation, which is a presentation that I'm going to give on teledermatology based on 3D total body photography. My presentation is essentially on the AceMed project, which is occurring in Australia at the moment, but I'd like to acknowledge Peter Soyer's leadership of this project. So Peter's here with us today. That's right, thank you very much. So as I said, presentation is teledermatology based on 3D total body photography. So essentially this presentation is a case study of the Australian Centre for Melanoma Imaging and Diagnosis, or AceMed. It's the AceMed project that's currently running. So AceMed is a research project and it's been funded by the Australian Cancer Research Foundation. And it's a collaboration between three universities on the eastern, corresponding to the states of the eastern seaboard of Australia. So the University of Queensland based in Brisbane, the University of Sydney, and also Monash University. So like I say, it's a research project, and the three questions that it aims to answer are: can a melanoma screening program based on total body photography and teledermatology improve the early detection of melanoma? Is such a screening program cost effective? And what are the effective characteristics of such a service? So the objectives of the AceMed program is to implement a melanoma screening program for high-risk patients, and it's going to be based on total body photography in lieu of an in-person full body examination, and it's going to be based in teledermatology. One of the issues in Australia is the high rates of melanoma, particularly in rural and remote areas of Australia, and so same areas that don't have access to a dermatologist. So one way of obviating these problems is the use of teledermatology. So the technology that we decided is 15 total body photography devices, and they have been implemented into 3 state-based clusters. And the final objective of AceMed is to implement a research repository. So this research repository is an amalgamation of all of the images acquired from the 15 total body photography units. Now, in addition to those, we have what we call the AceMed cohort study, where we're collecting patient information, patient questionnaires, sun exposure history, occupational history, medical history, and amalgamating those with the images into the research repository. One of the primary aims is for the development of AI or machine learning applications. So the idea of having these total body photography as well as the other associated demographic information, I think, is quite a delicious proposition to AI developers, machine learning developers. And just a schematic representing what we're doing is that we've got the 3 state-based clusters implementing images into a state-based clinical research repository for clinical application, and all of those images being moved to a research repository for consenting patients. And again, if you're not familiar with the geography in Australia, this project is Queensland, New South Wales and Victoria, which encompasses the eastern seaboard of mainland Australia. So I'm framing this in a design sciences methodology. So look, unlike other frameworks we've heard that are aiming at implementing an evidence-based practice, we're actually designing a service. So we use this design sciences. So we identified a problem: high incidence of melanoma in Australia. We define the objectives and solutions, and I'll just reiterate what we've done there in terms of a melanoma screening program using total body photography and teledermatology. But I want to concentrate most of this presentation on this next step here, which is the design and development. In design sciences research methodology, it talks about designing artefacts that are going to be used to the components of these systems coupled together to actually provide the service. Then once we've designed it, it's the demonstration. And this demonstration is what we're terming the AceMed research project, which is in fact a pragmatic trial of what we're trying to develop there. We need to evaluate these demonstration programs, and like most other implementation frameworks, there's this iterative cycle of improvement, and that's largely where we are at the moment, and it's largely where we're going to be for quite a period of time subsequent to this. And again, just to highlight the objectives of what we're trying to achieve there. So the 4 artefacts that I want to concentrate on in terms of building the AceMed program are patient subjects, the technology and the architecture, the imaging protocol, and how we get results out of this system to the referrers. We risk stratify patients using the Melanoma Institute of Australia risk assessment score. Now, we aim at implementing a screening program for high-risk patients, but where the high watermark and the low watermark is for high risk, we don't know as yet. So we're imaging all patients, low risk, medium risk, high risk patients as part of this. And we use this risk prediction tool from the Melanoma Institute of Australia, where I've put the URL there of that tool. It's a fairly simple and quick tool. So patients are stratified using that, and then they're imaged. I imagine most people are reasonably familiar with the technology that we've chosen to use. We're using the Canfield Vectra system, which is a 3D total body photography. The Canfield system is pictured on the screen here. It has two gantries, a forward-facing gantry and a rear-facing gantry. And in each of those gantries, there's 46 digital cameras, each at a different angle. So you can see that the patient stands in between those in such a pose. And the software controls all 92 cameras in a single exposure. So what we produce is these 92 images of the patient there, and the software renders those into a 3D avatar, and that 3D avatar can be pan-tilted and zoomed to such an extent that you can examine an individual lesion. We talked about that we're going to organise these into three networks, three state-based networks, but we didn't want these imaging devices to be standalone devices. We wanted them to be integrated into the digital health ecosystem of the host hospital, and we wanted to use existing healthcare standards, namely HL7 and DICOM, to achieve this. So we've got the 5 imaging devices there, and they get context information, such as the patient demographics, study demographics, clinical information that comes from upstream systems, and these are transferred using HL7. We know that from studies that if an operator enters demographics manually into a device, you have to up to a 20% misidentification of patients. So this is one of the other reasons that we wanted this integration. So all of those imaging devices send the images to a image archive manager database, which is essentially the Canfield demographic system. And associated with that is the demographic software, where a dermatologist will produce a report. They'll review the images and produce a report in a not dissimilar workflow to what radiology does. And again, we didn't want those results to remain only in the demographic software, which is largely available to only the dermatology community, but we wanted those results to go to the electronic medical record using, again, standardised health interoperability HL7, and we also wanted to store the images to DICOM. So using the existing hospital packs or the existing hospital enterprise imaging repository, that those images were then stored in DICOM format for distribution for the hospital and long-term archiving. So the imaging protocol, like I say, it's based on 3D total body photography, but in addition to the 3D total body photography, we do dermoscopy, and the dermoscopy protocol is for lesions greater than or equal to 5 millimetres, and any lesion in concern to the melanographer or any lesion in concern to the patient. So once we've produced these lesions, a dermatologist review them. They may be transmitted from one of those regional remote sites to a location where there is a dermatologist, and they use the demographics software, which is a component of the Canfield system, to produce a report. And we designed this report to try and make it as simple as possible for a dermatologist to do a report. So for this reason, we used a series of text box and drop-down lists so that they could review an image and produce a report. So this is just a picture of the user interface there, and I've just got highlighted there a couple of drop-down lists where they can use a drop-down list to enter the provisional diagnosis, or the dermatologist can also highlight a recommended management plan. So provisional diagnosis is based on those 7 disease conditions that are listed in the left-hand column there. These have come about from what was defined for the HAM 10,000 data set in terms of a diagnosis applicable to pigmented lesions, and the recommended management plan in the right-hand column. So once they've entered this in the system, it produces this sort of text-based report. So you've got patient information, a lesion summary, you've got an overview image, you've got the dermoscopic images, and you can see there the recommended management plan, the provisional diagnosis, and also an opportunity to enter free text results there. So that can be formulated into a PDF, which can be printed out or electronically sent to the referrer, can be encapsulated as a DICOM object and sent to the PACS system, or it can be sent via HL7 to the electronic medical record, so it forms a permanent part of the patient's medical record. So where are we up to in this project? Well, we've identified the problem, we've defined the objective, we've done most of the design work. So we're with this demonstration stage here, and dare I say that we'll probably be at this demonstration page. A project this ambitious is, we probably didn't realise how many problems that we were actually going to come across. So we're at this iterative stage of demonstration, evaluation, improvement, and everything like that. And as I say, I anticipate we'll be here for quite a while. So at the next biannual meeting, I'd like to come and present again. So maybe we'll get a little bit for further results. So thank you.